Now, so this is the MedCognito MCCQE1 web class. And today we're going to consider some very, very important secrets we have to know in our exam preparation. And we're going to use MCCQE1 Objective 54. We're going to use, Objective 54. The concept we believe in is that every objective has to be covered. And, I know there are a lot of conversations going on in our chat rooms and everything, and people go like, oh, I use this book, I use that book. The reason why I don't normally subscribe to using a particular book is because, it is not enough to just read the whole book. At times you may be reading a book and some of the topics you are reading are not examinable. And that is why I encourage that we always make sure that we are using the MCC objectives, so that if you pick what is in the MCC objective, then you rather go into the book, whether Toronto Notes or Master the Boards, or I prefer Up to Date as your reference material. So let's jump in secrets to know in MCCQE1 exam preparation. And today we're going to use the MCCQE1 Objective 54 as our case study. Now, we're going to use the objective to study. High yield facts you must know as a candidate so far as MCCQE1 Objective 54 is concerned. Objective 54 is talking about lymphadenopathy. And so in your exam preparation, according to the MCC, number one, you've got to know the location and presentation of lymphadenopathy. And so tonight we're going to look at what does it mean to have localized lymphadenopathy? What does it mean to have diffuse lymphadenopathy? What is the clinical significance of benign or malignant lymphadenopathy? Very, very critical. And the high yield facts you must know as a candidate are that lymphadenopathy can be localized or it can be diffused. Now, a lot of people in our learning usually think that when lymphadenopathy is localized, then it is benign. If it is diffused, then it may have some malignant potential. But after this lecture, you'll realize that no, lymphadenopathy can be localized and be malignant, or can be diffused and be non-malignant. We also will have to know the infectious causes of lymphadenopathy, inflammatory causes of lymphadenopathy, and neoplastic causes of lymphadenopathy. And all this information is coming from the MCC objective book. So if you don't have it, you can send us an email or you can send us a DM in the group and we will forward one to you, because I'm not the one who generated it. It's from the MCC. All right, good. Now, in your preparation, especially with that particular objective, you have to focus on things like, what are the causes of lymphadenopathy? How do I determine the severity of lymphadenopathy? Some questions are coming through already. Okay, and what are some complications associated with lymphadenopathy? We'll look at all that tonight. And what are appropriate management plans for lymphadenopathy? And when do you initiate those specific plans? But one thing you have to also notice that going into the exam, the QE1 can be a bit tricky. You have to ask yourself, what are some of the indications for lymph node biopsy? Because in the exam, they can ask you, they can give you about 30 options and tell you to choose the best 5, or to choose the best 3, or to choose the best 10, or ask you to fill in. So these are the things I'm highlighting in red, so that you can be able to pick them up while you are studying. Now, based on the objective, you have to be able to tell the clinical findings which are associated with lymphadenopathy. That's number one, doctor. Number two, you have to know how to interpret the clinical findings associated with lymphadenopathy. So, for example, if somebody has matted lymph nodes, that is what is given in the objective or in the question stem. What does it mean? And then you also have to know the relevant points in the history of a patient who presents with lymphadenopathy. So, for example, what are the clues I need to pick up in the question stem? which will point me to toxoplasmosis, or which will point me to sarcoidosis, or which will point me to HIV. Okay, these are all the things I want us to start paying attention to, so that when we are preparing for the exam, we are hyper vigilant. Because in the exam, you need to pick some critical points, and that is what will help you to get the marks you need. Now, of importance is also investigations, labs, radiological studies, which are requested for evaluation of patients with lymphadenopathy. Okay, so when you are learning, this is the framework you have to use. That is the MCC's own suggestion to you. So don't do anything outside the objective they've asked you to do. Now, based on the enabling objectives, so you realize that when you have the objective book, they have the objective itself, and then under each objective, they have what you call an enabling objective. The enabling objective will tell you that you have to determine whether, when somebody presents with lymphadenopathy, you are going to do basic observation or you are going to treat the person right away. And the enabling objective also helps us to know if we have to determine if the patient requires urgent or non-urgent referral. The reason why I'm saying this is because, you know, in the exam, they are going to see the importance you place on, number one, safeguarding the Canadian healthcare purse, and number two, the ability to also pick up patients who need urgent referral. Because you know that doctors have gotten into trouble for maybe not referring patients appropriately. Maybe the patient needs to be seen as quickly as possible. The doctor didn't do that, or if the patient didn't need that, the doctor, you know, use resources, because resource allocation is very important in Canada. And the C is that you have to counsel and educate the patient regarding the nature and the scope of the needed investigations. Okay, so now this is the first point I want to draw attention to. We have to understand that Canada has a principle of choosing wisely, and that is why the QE1 exam is designed as how it is. It is not every lymphadenopathy you biopsy. And you realize that we have a website called Choose Wisely Canada. And I'll show you the link to that website, because it is one of the MCC recommended websites you need to use to prepare for your exam. So this is what UpToDate says, that biopsy is sometimes the to reach diagnosis in a case of lymphadenopathy, but it should be used judiciously. So the question is that, for example, in your MCCQE1 STEM, if you get a case and there's one of the answers is biopsy, is it every case you're going to biopsy? You have to know. Choose Wisely Canada should be able to help you to know, okay, which of the patients should I biopsy? Which ones should I not biopsy? Which ones should I just do careful follow-up? So this is the website to Choose Wisely Canada. Do I need to biopsy? Do I need to give antibiotics? Do I need to do this? We have principles there. I've put it in the comment section. Choose Wisely Canada. So Choose Wisely Canada. This is a very important site you need, because it helps you to know, you know, what do I do? Which patients do I biopsy? Which patients, you know, maybe a 45-year-old female with breast concerns. Do I do ultrasound? Do I do mammogram? These are the things Choose Wisely will help you to do. Now, going back to lymphadenopathy, you've got to know your lymph node groups. And this is not just for QE1. It is also necessary for NACOSCI, especially in this situation where you are verbalizing a lot of your examination findings. So you have to know that we have the supraclavicular lymph nodes, we have the deltopectoral, the axillary lymph nodes, the epitrochlear lymph nodes, and keep the word epitrochlear in your mind, because I'll be coming to that. Use it as a hook in your mind, because I'll be dropping a question on that while we go through the lecture. You have to know your inguinal lymph nodes. You have to know your popliteal lymph nodes. And even when we get to the cervical lymph nodes, so when you get to the cervical lymph nodes, for example, in case you are doing a QE1, a NACOSCI exam as well, these lymph node groups are important for you to have in your mind, like occipital group, post-auricular, superficial cervical, deep cervical, posterior cervical, you know, pre-auricular, parotid, tonsillar, submental, submandibular. As I said, you're going to have this video. So don't worry about that. As soon as the class is done, I'm going to load it into the Facebook group and you can access it at any time. Now, another group of things you have to know are pathologic causes of lymphadenopathy and medication causes of lymphadenopathy. You've got to know that not every lymphadenopathy is caused because of a disease condition. Some lymphadenopathy is caused because the patient took a medication, and if you go into the exam without that knowledge, that becomes a bit problematic. Okay, so that is, I'm going to show you a slide with all those things. So for example, when you are watching the replay and you get to this slide, I'll need you to pause and take some notes, because I'll need you to pause and take some notes. I think somebody is writing on the slides, but that's cool. We'll go again. So now, if somebody presents with localized lymphadenopathy, what are the differentials? Because with this alone, we can generate a whole list of questions, just this case alone. So what they can do is they can list, okay, choose as many as apply in terms of localized lymphadenopathy. Then they can list about 40 options. Okay, toxoplasmosis, leishmaniasis, histoplasmosis, coccidiomycosis. Then they will drop something like streptococcal pharyngitis, tularemia, plague. And it is up to you, after you've studied a table like this, to be able to know that these are the causes of localized lymphadenopathy, these are the causes of generalized lymphadenopathy, and so I have to choose these options, I have to leave these options out. Aside that, we can even drop another question of the following are bacterial causes of lymphadenopathy. Choose the best 5. Then we drop things like rat bite fever, early Lyme disease, brucellosis, and then drop things like Mycobacterium tuberculosis, histoplasmosis, leishmaniasis, squamous cell cancer of the head and the neck. The well-prepared candidate will focus on these as the differentials. The one who is just choosing topics or answers anyhow will just go around choosing anything and will lose a lot of marks. So that is something I want to draw attention to. When you get to this slide, please take your time, pick a paper, try to draw a schematic diagram, bacterial causes, viral causes, mycobacterial causes, fungal causes, protozoal causes. Even with the bacterial causes, what are the localized ones? What are the generalized ones? Try to generate questions out of this slide alone, so that no case in the differentials or the pathologic differentials of lymphadenopathy can beat you. That is how I want us to train ourselves when we are preparing for the exam. The next group of conditions are the lymphoproliferative. So look, you can have a link with, say, 40 different conditions, and whoever is setting the question can just put in so many conditions, and it will be up to you for you to be able to decipher which of them is lymphoproliferative, which of them is immunologic, which of them is endocrine. Okay, and that is why I love the power of video replays, so that you can take your time and review this. All right, now remember that I made mention of drug causes of lymphadenopathy. So common drugs are common. So allopurinol, atenolol, captopril. So you have to know at least maybe 5 drugs. So because don't forget that the CDM portion, it can either be choose the best 5, or it can be put in the best answer. Because it is not always that you'll be given the option to choose the best 5. What if the question demands that you put in the best answer? So if you have at least some 5 differentials of medications which can cause lymphadenopathy, then you know what to fall onto. So allopurinol, atenolol, captopril, carbamazepine, cephalosporins, ethoxysucimide. We use that for some form of seizure. Okay, gold, hydralazine. We use gold for rheumatological conditions. Okay, other conditions like even common penicillin, phenytoin for seizures, quinidine, sulfonamide. So I want to really let you make sure that you've gotten this. Please, if you are following up to this point, Why don't you just type in yes or something so that I know that you are following me and you're not just quiet? So somebody is saying, is this better than up to date? Is this better than up to date for all the information needed for topics? No, this information, frankly, people are scared of up to date, that the information up to date is a lot. And it is the up to date information and other information from, and I'll show you some of the books we are using. Tintinali is a book the MCC has suggested. Harrison is also a book the MCC has suggested. So the information you have here is a combination of all these. But if you are sticking to up to date, that would be a wonderful resource. Now, another thing we have to also focus on is in the question stem. For example, they may want to say that, look, in the question stem, for example, they may want to say that, for example, two friends went to or if a patient comes to you in the clinic and in your evaluation, you know that the patient has lymphadenopathy. But then the question says that the patient recently attended a party of a friend, and during the party, meat was cooked. As soon as you hear that, and then you remember this table, and you can link undercooked meat with toxoplasmosis, all you need to do is you go to the options and then you look for where toxoplasmosis is, because it is an exam taking strategy. We call these links. So the question says, oh, the patient has a cat at home. The cat is immunized, but recently the patient had a cat scratch. Okay, or maybe the question says that the patient is a high risk sex worker. That should point you to things like hepatitis B infection, HIV, syphilis. So at times the preamble should help you to know that Jay is asking me, thanks for showing the books. Can you please share all the books, websites, and other resources you recommend to be used for QE1 and NACOSKI? Awesome. I will do that. I have all of them, and I'm going to share them all with you. Preparing for the QE1 exam shouldn't be, something which is like in some dark hole that you don't know what to do. The information out there is abundant, and you shouldn't worry about where to get information from at all. Awesome. So Esther Snow says that, thank you. Awesome. So I think I like the energy in the class right now, and we are continuing. Awesome. Let's continue. So another thing you also have to look out in the preamble. So now we've looked at medications. We've looked at pathologic causes like viral, bacterial, lymphoproliferative causes. We've looked at types of medications. Now, while you are reading the question stem, ask yourself, is the question stem pointing me to the patient's occupation? Because some specific occupations can also lead to lymphadenopathy or some exposures in some specific occupations. So, for example, if the exam question states that the person is a fisherman and recently returned from a fishing trip and came in with lymphadenopathy, I'm not going to go for sarcoidosis. I'm not going to go for hepatitis C. I'm going to go for erysipeloid, because that is what is linked with fishermen and fishmongers. Please, are you following me? So what I want you to do is that while you are learning, start picking patterns. Don't just say, oh, lymphadenopathy. Oh, I know lymphadenopathy. No, there's a lot which we can set almost 100 questions on lymphadenopathy alone. And that is what I want you to start doing. When you're preparing for your exam, start asking yourself, I'm not just reading material. Can I set questions myself and try to quiz myself to see if I can ace this exam? Another thing you also have to pay attention to is travel history. So, for example, if the question stem gives, say, the person traveled from Mexico or Peru or South America somewhere or Egypt, I'm not going to think about coccidioidomycosis. I'm going to think about typhoid fever. But if the question says the person is recently coming from Arizona, Western Texas, then I'm going to think about coccidioidomycosis. Doctors, I don't know whether you are following what I'm saying. Like, I think if you are following me with all the patterns we are drawing, Good, good, good. Somebody says more power to you. Awesome. Okay, so let's go on. So now, let's talk about even the causes of cervical lymphadenopathy. Cervical lymphadenopathy, because you know what? Now we've looked at the occupation, we've looked about travel history, we've looked at medication. Now let's look at even the distribution of lymphadenopathy and you know where it is, because now the examiner can go on to say that, oh, somebody came in with lymphadenopathy, but the lymph nodes were noted in the anterior cervical lymph node groups. That should point you to a particular group of or a particular differential like Epstein-Barr, cytomegalovirus, toxoplasmosis. And if it is in the posterior cervical lymph node groups, then you're looking at things like tuberculosis, lymphoma, head and neck malignancy, you know, metastatic squamous cell cancers. Okay, now with the same lymphadenopathy, let's look at clues to pick up, which will point to tuberculosis with lymphadenopathy. Because most of the time, many of us, there are things we know about tuberculosis is, oh, maybe the person has come in contact with somebody with chronic cough, maybe the person has been incarcerated before or been in prison before, you know. But what are other things I should look out for? Sure, Dr. Sawa says gastric malignancy and supraclavicular group. So, Mycobacterium tuberculosis and its lymphadenopathy. What are the things you have to look out for? When the examiner is telling you that there are multiple enlarged lymph nodes, multiple, and you realize that these ones, so in a question stem, look at the clues they are given. Did it say it has been a couple of weeks or months? Is it becoming more fluctuant? Is it matted together? And maybe the examiner may say, oh, when you touch it, it is not tender. And occasionally the patient has night sweats or fever. So what you have to know is that tuberculosis adenitis is usually regional, except one case. So even when you're also looking at it and you're looking at the differentials and the options, and it says that, oh, the lymphadenopathy is only in one area, if you go and choose something like miliary tuberculosis, you know you are wrong, because miliary tuberculosis will present with generalized lymphadenopathy. So I'm trying to let us pick up on exam taking strategies as well. And then clues to pick up in a question stem about metastatic lymphadenopathy, because at times the only way at times some cases of metastasis can be picked up is all of a sudden the patient sees maybe a lymph node popping up somewhere. So with metastatic lymphadenopathy, what are the pointers? Usually the lymph node is hard, and they are usually in the cervical nodes. I think someone just dropped off. So look, if you have a friend who is waiting in the waiting area, tell them to fill in, okay? Older patients, smokers, and usually it is in the oropharynx, the nasopharynx, the larynx, the thyroid area, and the esophagus. That is where a lot of the metastatic lymphadenopathy may be coming from. Now, another group of lymph nodes you want to pay attention to is supraclavicular lymphadenopathy. Supraclavicular lymphadenopathy. So the supraclavicular lymphadenopathy, you even have to look at the question stem. Is it saying that the lymphadenopathy is on the right? Is it on the left? If it is on the right, you're looking at usually cancers in the mediastinum, lung cancer, esophageal cancer. Okay, if it is on the left, then you're looking at things like the Virchow's nodes, that is abdominal malignancies like stomach cancer, gallbladder cancer, pancreatic cancer, kidney cancer, testicular cancer, ovarian cancer, lymphomas, prostate cancer. So what am I trying to point at? In preparing for your exam, when you take the objective 54, know the medications, know the distribution, know the occupation, know the travel history, know the person's social habits, which of them have been dropped in the case. Now, when you move further, assuming they want to examine you on physical exam, where is the lymphadenopathy? Anterior cervical, posterior cervical, supraclavicular, even supraclavicular, is it on the left? Is it on the right? All right, good. Now, something unique about epitracheal lymphadenopathy. Epitracheal lymphadenopathy, that is lymphadenopathy on the elbow. There's something unique about it that UpToDate said. So I want us to look at this question. While I read this note from somebody says syphilis. Okay. So a 65-year-old male came to your clinic for a routine complete physical exam. I want you to give me answers in the chat box. You note epitracheal lymphadenopathy on the right arm during palpation. List 3 pathologic causes of epitracheal lymphadenopathy. Please, I want to see the answers. Let the answers flow. Let the keyboard warriors start doing their magic. Let the answers start flowing. Dr. Tasmin says syphilis. Any other? Can anyone else help? What other answer can you give? Mycobacterium leprae. So you are talking about leprosy, HIV. I want 3 pathologic causes. So Dr. Lavanya says Mycobacterium leprae. Dr. James says HIV. Dr. Happy says infection. No, Dr. Happy, infection is non-specific. Dr. Prinka says syphilis and sarcoidosis. Dr. Happy says sarcoidosis. Dr. Sawa says lymphoma. Maybe not to waste your time, melanoma as well. Awesome. So, differentials of epitracheal lymphadenopathy. And there's something unique about epitracheal lymphadenopathy. Cellulitis of the forearm, lymphoma, sarcoidosis, tularemia, and secondary syphilis. So whoever said syphilis was right. Okay? And whoever said lymphoma is also right. Now, I want to give you this fact you must know about epitracheal lymphadenopathy now that you're going into the exam. You have to note that at times you can, when you palpate the cervical lymph nodes, you may palpate 1 or 2 lymph nodes. But in the medical literature, and the source is up to date, palpable epitracheal lymph nodes are always pathologic. Palpable epitracheal lymph nodes are always pathologic. So you must note that for sure. Always pathologic. Palpable epitracheal lymph nodes. So if the case gives you that, oh, the doctor found lymphadenopathy and it was noted on the epitracheal region, think about a pathologic cause. Don't just brush it aside. And even when you start practicing, or when you get into your residency programs, or when you get into your practice ready assessment, palpable epitracheal lymph nodes are always pathologic. Now let's talk about inguinal lymphadenopathy. I have a question again. A 54-year-old patient came to the clinic for evaluation. You notice inguinal lymphadenopathy. He inquires about the causes of his presentation. List 5. Let's go. So this is how our mock sessions look like, okay? A 54-year-old patient came to the clinic for evaluation. You notice inguinal lymphadenopathy. The patient inquires about the causes of inguinal lymphadenopathy. List 5. Can I see some of the answers? Can I see some of the answers? Dr. Maria says cervical cancer. Dr. Mansukru says metastasis. But Dr. Mansukru, please be specific. Metastasis from where? Dr. Arun Paul says epididymitis. Dr. Amar says infections. You see, Dr. Amar, it may be right, but then which kind of infection? Dr. Maria says endometrial cancer. Dr. Surya says UTI. Dr. Tu says prostate cancer. Dr. Sola says chancroid, vulvar cancer. You know, he is being specific. Awesome. Oh, 15 more answers. Wow, that's awesome. Appendicitis. Well, maybe, you know, appendicitis is at times so acute that you may not get lymphadenopathy right away. But what are the answers? Lower extremity infection. So cellulitis of the lower leg, erysipelas, you know, chancroid, lymphogranuloma venerum, genital herpes, syphilis. So cancer, so various cancers in the groin. So vulvar cancer, cervical cancer, endometrial cancer, ovarian cancer.
We can't hear you, doctor.
So these are the differentials for inguinal lymphadenopathy. So you see, while we are going through, I've seen people writing infection. No, don't just write infection. Even me with this lower extremity infection, it is not specific. I should have written something like erysipelas or cellulitis. That helps. Behçet's disease. Okay, now another question. You are working with a pathologist today. His aim is to find various causes of inguinal lymphadenopathy. He is reviewing both males and females today. Which of the following sources of malignant inguinal lymphadenopathy is the least likely? You see, the initial type of questions I brought were feeling, but now we've given you options and you've got to choose the best answer. Which of the following causes of inguinal lymphadenopathy is the least likely? Which answer are you going for? Please choose your answer. Someone says D. D is cancer of the skin of the trunk. H is cancer of the penis. Okay. H again, we have two H's. Someone says cancer of the skin of the lower extremities. Someone says B. So what does the literature say? The literature goes for H, cancer of the penis. And this is the teaching point. In one series of 2,332 patients with malignant inguinal nodes, the primary site in descending order of frequency was skin of the lower extremities. So that is the top to the lowest. Cervical cancer. So that means cervical cancer is likely to give you lymphadenopathy in the groin than anal cancer. Vulvar cancer, skin of the trunk, rectum and anus, ovary, and the last is cancer of the penis. Okay, so cancer of the penis is the least likely to give you inguinal lymphadenopathy. Are you enjoying the questions? Are you enjoying the questions so far? And is this opening things up to you? Because for me, I see people oh, doctor, I've crammed the book. I'm like, no, it's not enough to cram the book, my dear. It is not enough. You've got to know what the book says. Okay, let's do another question. You are in the clinic in rural Manitoba. You have seen quite a number of patients who have come in today with generalized lymphadenopathy. List 5 pathologic differentials of generalized lymphadenopathy. My keyboard warriors, let's go. Yes, so Dr. Ryder says questions help to understand well. Exactly. It is not enough to just sit and read. So for example, while you are giving me your answers, let me show you something. For example, we have Tintinali here, okay? Maybe when you get into your emergency medicine residencies and everything. But at the same time, I've gotten what? Tintinali examination review board questions. So when you are studying with questions, that helps. Rather than just, reading, thinking that you understand. No, it is not enough to read, my dear. You need to read, but you need to also understand. So somebody says hepatitis B. So what are some of them? HIV, Mycobacterium tuberculosis, Mycobacterium avium complex, okay, Mycobacterium scrofula, infectious mononucleosis. Everyone missed that one. Okay, systemic lupus erythematosus, SLE, sarcoidosis, Hodgkin's lymphoma, non-Hodgkin's lymphoma, amyloidosis, and sarcoidosis. So if you have about 5 of them in your mind, generalized lymphadenopathy, when the MCC asks me, I can give it to them. Then you know that you are in good company. I did not miss, Doc. Dr. Ahmad, I don't understand your message. Maybe you can clarify it. Okay, so let's go on. Another question. Lymphadenopathy on fleek today. You are in the clinic in rural Manitoba. You have seen quite a number of patients who have come in today with generalized lymphadenopathy. During your evaluation, list 4 questions to ask the patient in the history. I've already covered this, but I'm testing you on it. During your evaluation, list 4 questions to ask the patient in the history. So what are some of the questions you want to ask? Constitutional symptoms, but don't just say constitutional symptoms. Be a bit specific. Okay? Weight loss, awesome. Occupation, awesome. What else? Contact with the sick, awesome. Travel history. People are getting the concept. I'm very happy. Sexual history. How long has it been noted? Time. Is it painful or painless? Fever, weight loss, awesome. What are some of them? Okay, some of the answers are history of localizing signs or symptoms suggesting infection or malignancy, exposure to cat scratch. You remember cat scratch disease? History of eating undercooked meat, toxoplasmosis, history of tick bite, history of travel to areas with high rates of endemic infection, history of multiple sexual partners, injection drug use, history of fever, history of night sweats, history of weight loss, use of medication. I don't even see anybody talking about medications. I think we are now getting the concept well. Okay, good. Another question on lymphadenopathy. I'm losing my voice already. So exposure to animals, awesome. So you are in the clinic in Rural Manitoba. You have seen quite a number of patients who have come today with generalized lymphadenopathy. During your evaluation, list 4 characteristics of lymph nodes you will need to pay attention to. What are some of the characteristics of lymph nodes you want to pay attention to? 4 characteristics. Let's go. Doctors, let's go. So this also tells you next time if you are joining this Zoom session, join with a laptop. Don't join with a phone because you need to type, because we will always set questions. We will always bring questions for us to use, okay? So list 4 characteristics of lymph nodes you will need to pay attention to. So characteristics, size, shape. Awesome. Is it fixed or mobile? Dr. Yasmin, you are killing it. Is there any discharge? I like that. Dr. Nabila says, location, size, awesome. Dr. Nabila, we are asking for 4. So if you can give me all 4, then you get your full mark, right? Good. Is it matted? Is it erythematous? Good. So the answers are, what's the symmetry? What is the location? Because remember that the location can tell me if it's an intra-abdominal malignancy or it is mediastinal malignancy. The location can also tell me something. The size, the consistency, is it fixated? Is it tender? All right? Awesome. No, Dr. Tasnim, we are asking about characteristics of the lymph node, not constitutional symptoms, the characteristics of the lymph node itself. Okay? So the constitutional symptom may be right if you are looking at the history. But you see, that is another thing. When you are answering the questions, you've got to pay attention to what the question stem says. Another question. You are in the clinic in Rural Manitoba. You have seen quite a number of patients who have come in today with generalized lymphadenopathy. During your evaluation, you note that one of your patients has associated splenomegaly. Now we've introduced another concept. Lymphadenopathy with splenomegaly. List 3 differentials. Oh my goodness. Someone has gone for Epstein-Barr. Epstein-Barr is the usual culprit here. Infectious mononucleosis, lymphoma. Awesome. What are the answers? Lymphoma, chronic lymphocytic leukemia, CLL, acute leukemia, and infectious mononucleosis. Okay, good. Another question, lymphadenopathy. You are in the clinic in Rural Manitoba. You have seen quite a number of patients who have come in today with generalized lymphadenopathy. List 5 investigations to request. So you see the way we've progressed from history through physical exam, and now we are going to differentials, and now we are going to investigations. Investigations, doctors, investigations. ESR, monospot tests, CBC, ACE, awesome, Dr. Lavanya, awesome for picking that up. ACE, oh my, and then Dr. Salma, you went for CBC. You know, in the MCC exams, we don't encourage, CBC. Rather, you may want to say hemoglobin, white blood cell count. Somebody is going for chest X-ray. So what are some of them? So serum white blood cell count, hemoglobin levels, blood film comment, TSH, HIV, RNA, VDRL, monospot test. Now, I think this time some people are right because we should have also added chest X-ray and the rest. The reason is because the question said list 5 investigations. If the question had said list 5 blood investigations, then we would have only done blood work. So with the chest X-ray and the rest, that is also right. Okay. Now, back to teaching. Imaging tests in lymphadenopathy that you can consider are computer tomography, that is CT scan, ultrasound, Doppler technology, magnetic resonance imaging. So another question. You went to work with some interventional radiologists today. They were performing lymph node biopsies on a number of patients. Which of the areas of biopsy are least preferred site for biopsies? Choose the two best answers. Least preferred. Least preferred. Least preferred. Choose the two best answers. Least preferred. So someone is going for A and B. And someone is also going for A and D. Someone is going for A and D. So people are going for the groin, the groin, the groin. The least preferred. Now, the answer is C and D. C and D. And what do I mean by that? C and D. Teaching points. If no single node predominates, so in other words, if the person has generalized lymphadenopathy, the choice in descending order of preference, so from is supraclavicular is the one you want to encourage more, neck, axilla, and groin. So the axilla and the groin are the two least favored places you want to do your lymph node biopsies. Assuming, so you have a patient who has cervical lymphadenopathy, supraclavicular lymphadenopathy, epitracheal lymphadenopathy, generalized lymphadenopathy, and you want to choose the two last places you want to go, it should be the axilla and the groin. The two best places you want to go, supraclavicular and the neck. Okay? And someone will say, oh, but the neck has a lot of vessels. But at times, it depends on the neck triangle you are going for. There are a lot of safe spaces where you can do your lymphadenopathy. Another question. A 54-year-old male with lymphadenopathy comes into the clinic for evaluation. You suspect that he has developed chronic lymphocytic lymphoma from your history. What is the gold standard option to make a definitive diagnosis? Gold standard. Gold standard to making a definitive diagnosis. What is it? Gold standard. A biopsy. Biopsy. Oh, Dr. Sawa says bone marrow. No. So what is it? Excisional biopsy. So you see, it is not also enough to say biopsy, because it could be a fine needle biopsy. But the gold standard is
that will be the bulging of spinal cord, right, through the space.
Okay. So there are lots of biopsies, but if you want to be specific in your exam, then you go for excisional biopsy of the lymph node. And the teaching point is that fine needle aspiration should not be used for diagnostic purposes in lymphoproliferative disease. Excisional biopsy is the gold standard. Okay? Excisional biopsy is the gold standard. And the source this time is from Toronto Notes, page 12 of the hematology notes. Okay? So as I said, we combine everything to come out with our notes. So when is fine needle aspiration most useful in evaluation of patients with lymphadenopathy? Fine needle aspiration is helpful for recurrence of solid tumor malignancies. So if the question says the patient had, awesome, Dr. Sawa, awesome. So if the question says the person had a malignancy, maybe of a solid organ, and it has come back again, that is when fine needle aspiration becomes the answer.